Hello, everyone. I think a few people are still connecting, but we will slowly get started. Welcome, everyone. My name is Julia Shenderovich, and I am a reader at the Wolfson Center for Young People's Mental Health. So welcome back to our lecture series. This is the first lecture for this new academic year. And these lectures, as always, are open to all. And this lecture will also be recorded and posted on the Wolfson Center's YouTube channel, where you can also find previous lectures. As usual, the session will be 1 hour long. We will have time for questions at the end. You can post your questions at any time during the talk in the Q&A box, and we will review this towards the end of the session. Now, to the main reason we're here today. It's my pleasure to introduce our speaker, Professor Brendan Kohrt, who is a psychiatrist and anthropologist and brings a unique perspective to our lecture series with over 30 years of experience working on improving mental health services in countries affected by war, political violence, disasters, and other humanitarian crises. Professor Kohrt holds a professorship in psychiatry and behavioral health, global health, and anthropology, and he is also the director of the George Washington University Center for Global Mental Health Equity. As we will hear about today, Professor Kohrt also leads the WHO UNICEF EQUIP initiative, focusing on competency frameworks for mental health providers, working across a range of evidence-informed mental health interventions. Thank you very much for joining, and thank you to our speaker. Over to you, Brendan.
Thank you so much, Julia. Let me pull up my slides. All right. Well, I really appreciate this opportunity. It's a pleasure to be with you all. So as Julia was sharing, my goal today is to kind of talk through the EQUIP initiative and offer that hopefully as a resource for you, whether you're doing clinical work, training, community work, or more specifically humanitarian settings where there is really a desperate need to improve services for child and adolescent mental health. So in terms of disclosures, the EQUIP platform is a joint initiative of the World Health Organization and UNICEF. And it has been funded by USAID from the US government, and a lot of the development work and the tools has been funded by the US National Institute of Mental Health and also previously Grand Challenges Canada. So today I'll kind of cover 4 areas. I'll briefly introduce folks to the psychological interventions that are commonly used in humanitarian emergencies for children and adolescents. And then we'll dive into why it's important to look at competency of providers delivering psychological interventions with a focus on, as we try to scale these up, both in humanitarian settings and in many contexts around the world, to ensure that when we are doing psychological interventions, we're approaching it from a do no harm perspective. Then I'll talk about the specific development and our initial evaluation of the WHO UNICEF EQUIP platform, and then wrap up with some future directions for the resource and hopefully get many of you started using this. So I always like trying to start out with a couple of different scenarios so that listeners can kind of put themselves in maybe different buckets in terms of how they might take away some of the information in this discussion. So you may be somebody who has joined because you are already working in a humanitarian setting. Maybe you're working in Ukraine, in the Middle East, in parts of sub-Saharan Africa, and you are interested in improving the programs that you're already delivering related to child and adolescent mental health. Maybe you're a researcher based in a low middle income country or even based in a high income country, and you want more tools to really understand how psychological interventions are working and to really think with an eye towards scaling up and implementation science. And how can you promote competency during that kind of what we typically refer to as the voltage drop between when we're running a trial and then when we deliver a psychological intervention in a community and real world setting. Or maybe you're someone who's more involved in training mental health specialists, and EQUIP for you could be a good tool to train future psychologists or psychiatrists or social workers so that they're more equipped to be able to train and supervise providers in a kind of a non-clinical setting, so as that may be involved in community programs or school-based settings. A lot of the development that I describe here is available in a Lancet Psychiatry article that was published last year. So this goes through the 5-year process from 2018 to 2023 of kind of envisioning what EQUIP would be, doing a theory of change to map out the parts, and then a lot of the development and pilot work in 6 different settings around the world. So to share a little bit about my background briefly, I got into this work around the time of doing my PhD in the early 2000s, where I was focused on the experience of former child soldiers in Nepal who were returning from their role as combatants into their communities. And there was a desire to be able to develop psychosocial and psychological interventions for the returning child soldiers, as well as other children in the community and members of their families and schools and community more broadly. And it was at that time that we were really beginning to see a burgeoning of psychosocial interventions around the world, a lot after the 2005 tsunami, the 2010 earthquake in Haiti, and a number of other disasters, to the point where we are now, 20 years later, with a huge range of tools and a lot of strong evidence that this stuff can work, but also a need to improve the way that we implement these programs. The overall status of child and adolescent mental health and the state of the field in terms of what interventions and resources are available are covered very well in the recent 2021 UNICEF State of the World Children's Report that focused specifically around child and adolescent mental health. That raised a lot of concern around mental health during and after COVID, but also drew attention in particular to the plight of children and adolescents affected by humanitarian emergencies. We know that there are over 400 million children around the world who are exposed to conflict and political violence, 175 million children who have directly experienced climate-related hazards, as well as other disasters such as earthquakes. And there are almost 20 million children who are displaced. And in many of these settings, there are growing utilization of mental health and psychosocial interventions. But if we think about those interventions, what has happened in the field has been a shift from this being something that a clinical psychologist or a psychiatrist or a clinical social worker might do, to instead focusing really on the need to have non-specialists, community health workers, teachers, religious leaders, and other laypersons deliver these interventions so that they can be scalable. This has been quite widely popularized. Many people have heard of the friendship bench, even if you're not working in global health or global mental health. Other programs such as the Thinking Healthy program, the interpersonal therapy or IPT has been adapted for delivery by non-specialists, and a growing host of WHO and UNICEF published interventions such as Problem Management Plus or Self-Help Plus are now available. And almost all of those have undergone 2 or more RCTs showing clinical benefit. A rapidly being adopted intervention now focused on child and adolescents, especially those in humanitarian emergencies, is the EASE intervention, or Early Adolescent Skills for Emotions. And this is basically a 10-session intervention, 7 sessions that focus on adolescents, 3 that focus more on the caregivers, and it incorporates elements of problem solving, behavioral activation, and strengthening social support. And as I mentioned, there have been a number of trials with an overall individual participant meta-analysis that has shown benefit for children who have gone through this intervention. But the challenge is, as we try to scale EASE and other interventions, is how do we best train non-specialists outside of the research context? How do we be sure that in real-world settings, these interventions can be as effective as they were when under a highly supervised, rigorous research trial conditions? So a close colleague of mine, Mark Jordans, who directs research at War Child Alliance, and I have written a paper on thinking about this transition from the research space to the implementation space. And that idea of being, what have we learned through our research that can really guide the best quality of implementation in real world settings to ensure impact for psychological health and well-being. If we think about drugs, when we look at the area of say, drug trials, we study a medication, we ensure that it works for the intended populations, and then this goes out into the real world, and we assume that it is going to work in a similarly effective manner. When we evaluate medications in the real world, we're not constantly under trial conditions, but when medications are being generated, especially in the transition to, say, generic medications, we test things like the bioavailability. Is that drug expected to work just as well as the drug that was in the trials? Well, in the space of psychological interventions, we don't have bioavailability, but what we really look at is competency. And the idea that in a research trial on a psychological intervention, we want to be sure that we're evaluating what level of competency is needed by those individuals delivering an intervention, especially when it is a non-specialist like a community health worker or a teacher. And then have systems in place to evaluate that competency under those real world settings. And this really is trying to bridge this competency chasm that, people may be very skilled even if they're a non-specialist because of the type of training and supervision they get in a research trial. But then when we try to get this out to tens of thousands or hundreds of thousands of children and adolescents around the world, that we may not achieve that same level of competency. The other concern that has been raised as we try to proliferate more interventions in humanitarian settings and other low resource settings around the world is the question of, are we potentially doing harm? Again, under a research study that might be evaluated through adverse and serious adverse events, but we rarely have mechanisms in place to be able to evaluate that when we're scaling up in the real world. So competency provides a standardized and structured way to look at how someone delivers a psychological intervention that can be done through things like standardized role plays that doesn't require, say, observing every single session that someone is delivering and then trying to code those with often very complicated rating scales. When we think about competency in the field of psychological interventions, I go back to this Miller hierarchy that was developed in the 1990s. The idea that we can think about the knowledge of someone delivering a psychological intervention, how they apply that knowledge, but more important is demonstrating the skills to be able to do it, that often things like multiple choice tests or other approaches rarely capture how someone behaves when they're delivering a psychological intervention. So competency is a way to do that. And then, of course, there's always kind of the more challenging and context-specific, monitoring of actual delivery, which Miller refers to as the does level of the pyramid. So just a few more definitions. Often we think about treatment fidelity, and this can typically be rated through things like checklists. Did you do everything that was needed for an intervention to have its active ingredients? But we also need to look at really competency, which is how well those particular elements of an intervention are being delivered. And competency not only covers treatment-specific skills, but also what we refer to as the common factors, or sometimes referred to as non-specific factors. And the World Health Organization and UNICEF refer to these as foundational helping skills. So it's really the combination of kind of doing everything that you're supposed to for an intervention, but also how well you do it to then be able to ensure quality of care. But a challenge has been that rating competency often involves very elaborate kind of technical scales, things like the cognitive therapy rating scale, that can often be quite subjective and aren't easily used by people who are training non-specialists who they themselves might not have extensive clinical experience. So now we're getting into the reason why EQUIP was developed, really to come away with a tool that can be used around the world, even in rapidly deployed interventions with short trainings in humanitarian settings, but also could be used for non-specialists, peer and paraprofessional providers, even in high-income countries. Equip is really limited to client-facing direct interactions. So we were very deliberate. This doesn't involve professional conduct or ethics or even things like documentation. Those are all part of competency, but those vary by setting, by professional societies, by government guidelines. And so Equip is really designed as much as possible to be a universal, culturally adaptable tool to focus on particular behaviors. But other types of evaluation and monitoring can be done around things like documentation or professional ethics. So prior to the launching of the Equip initiative in 2018, colleagues Mark Jordans, Daisy Singla in Toronto, and Vikram Patel, as well as colleagues in Nepal, developed the preliminary tool, which was referred to as ENACT. And so what we did for that was to review a whole host of kind of doctor-patient or empathy-related tools or communication tools or common factor non-specific tools. From that, we found almost 60 different tools that were commonly in use and extracted from that more than 1,000 items, and then went through a whole range of kind of rating processes, culturally adapting processes, exploring this and piloting it in different humanitarian settings such as Uganda, Liberia, and Nepal, and then ended up with this tool, this competency rating tool called ENACT, Enhancing Assessment of Common Therapeutic Factors. It's not only a tool, but also a series of role plays that can be used, and then some guidance on doing this scoring. Based on the kind of success and demonstrated benefit of this tool, the World Health Organization came to me in 2018 and said, we want to really scale this up and develop a global platform to be evaluating competency, especially for humanitarian settings where there's rapid deployment of psychosocial interventions by non-specialists, but also then ideally to think more broadly around developing the global health, behavioral health workforce. So at the core of Equip are these common factors, and over the past couple of years, we've refined those to kind of 3 tiers: engagement, common factors, understanding, and support. These are all referred to as the foundational helping skills. But then there's also a series of treatment-specific competency ratings in the Equip platform of resources that might focus on skills such as behavioral activation or, say, cognitive or stress management techniques. Equip is a series of paper-based resources, but a major innovation is that it is also a live interactive platform that is free for anyone around the world to register and use. There are a host of kind of training resources on the platform, so people don't need to go through some formal course or certification to be able to use this. The Equip platform is designed to really try to improve the overall quality of psychosocial and mental health interventions, whether that's more kind of generic community-based psychosocial programs like, say, psychological first aid, but also specific interventions that might focus on things like CBT or behavioral activation. It's intended to be used for trainers and supervisors, as well as those that are doing program development and monitoring evaluation. It can be used for non-governmental organizations or academic institutions or kind of any other organization interested in delivering psychosocial care. It's a whole collection of different types of competency assessment tools, and I'll show you some of those that can be used to evaluate skills throughout training, and then after training and during supervision to ensure that people have the minimum skills necessary, and also that they're doing no harm in delivery to real-world clients, including children and adolescents. It also is a way to kind of monitor competency over time. So you can enter your competency evaluations into the platform and then track students or trainees to see areas of improvement and then focus on those. There are a number of courses for those that might not be familiar with competency-based education, which tends to be more focused on reaching benchmarks of skills rather than a one-size-fits-all 10-day training or 2-year training. It's really more of a flexible approach to training that has continual monitoring of skills. And then I just want to give a quick sample of the types of tools that we have. So this is one of the items in the ENACT, so the foundational helping skills. And this is nonverbal communication. And we built it to allow rating of specific behaviors. Although many tools in the field tend to use kind of Likert ratings of a 0 to 7 scale or a 0 to 5 scale, we found that in developing a tool that was going to be the most handy for trainers and supervisors to use, it helped to have specific behaviors that they could then capture. So is somebody laughing at a client, doing inappropriate physical contact, or making potentially kind of inappropriate facial expressions, allowing for silences, or maintaining appropriate eye contact, or maybe more advanced skills. So everyone who's using the tool rates both specific behaviors that they see under the different types of competencies, but then also an overall level score. And this was a movement away from some of the more traditional tools because people found when we were piloting it that the more traditional tools tend to be very subjective. When somebody would say, highly inappropriate, minimally inappropriate, highly appropriate, excellent, what one person saw as highly appropriate versus another tended to vary quite substantially. So in the end, having these benchmarks in terms of did somebody have an open body posture, did somebody explain confidentiality correctly, led to, on a research level, greater inter-rater reliability, but also greater ease of use overall. And then there's output on the platform. So it reports, say, for an individual, what level they were, but it also captures all of the particular behaviors. And trainers and supervisors really liked this because rather than coming away and saying somebody on verbal communication was a level 1 or a level 2, you can package your feedback with, hey, here are some things that you did well. I noticed you used a lot of open-ended questions. You allowed the client in general to kind of complete their statements before responding. But there's also some areas for improvement. At times when the client had a long answer, you might have interrupted them. But overall, you're doing good and even displaying some advanced skills, like you kind of constantly encourage the client to share more. So the trainers and supervisors in low resource settings liked this kind of guide to then giving feedback. And then as mentioned, there's a way to aggregate the results across your competency assessment. So if you're training a group, say, of lady health workers in Pakistan or India or Nepal, you're able to look and see which competencies they're struggling with the most. So in this group, what areas are the most difficult for them? And then also identify, are there particular people that you're training that are, again, not really kind of mastering some of the key skills, who you want to spend more time with because you're concerned they might potentially do harm when seeing real world clients and patients. And then there's guidance on the platform on giving feedback in a competency-based approach. And then you can track changes over time to look at improvement, our harmful skills being reduced, and our helpful skills increasing. And then also guidance on doing role plays. In many settings, when people are very tight on time, there might be a tendency to kind of revert to a very didactic approach, like I have right now, where I'm tight on time, but not really interactive and actually doing things like role plays. So Equip has also been really useful to help people encourage greater time practicing skills, doing role plays, using structured role plays to try and elicit different behaviors. This has been especially important around things like talking about suicide, that often when we just focus on maybe teaching people a risk assessment, but not having them sit there and try to do it, that time practicing really helps to develop their skills and be comfortable talking about something sensitive like self-harm. So as I mentioned, the platform includes a range of different competencies. So we have the ENACT tool, which is targeted for these foundational helping skills for adults. There's also a remote version. We were developing this in the midst of the COVID pandemic, so it was important that we also adapt for therapies that might be delivered over video calls or voice calls. Similarly, and of particular interest for you all in this audience, there is a child and adolescent focused foundational tool called the WeAct. There are also tools for group-based interventions, for specific WHO interventions like PM Plus, Self-Help Plus, and EASE, which I mentioned earlier. But then there are also tools for things like motivational interviewing, stress management, behavioral activation. And then there's also a series of role play videos. So when training people on how to use the competency assessment tools, it's great to have videos, some that demonstrate helpful behaviors, some that demonstrate harmful behaviors. It's a nice way to learn how to do the ratings. These videos are available in many different languages, Spanish, English, Arabic, some for children, some for adults. And it also can be a great way even to teach some of these skills by looking at different examples of helpful and harmful behaviors. It was important before kind of spreading this and disseminating it throughout the world to make sure we were doing feasibility testing in diverse settings. So we have evaluated this both with group and individual interventions and also for adult and child and adolescent interventions. So EASE was evaluated in Lebanon, also another child-focused TFCBT with adolescents in Kenya, and then Thinking Healthy program, PM Plus, the Johns Hopkins Intervention, CETA, and others. And what we can see here is that the tool was helpful to capture kind of changes over time, both the improvement in helpful behaviors, but also the reduction in harmful behaviors. It was also very nice to have kind of a standardized benchmark. Often we see, trainings of similar interventions around the world, but we really rarely kind of have a standardized way to compare them. So seeing that kind of very intensive approaches to training done by the Centers of Victims for Torture with PM Plus in Ethiopia tended to yield quite, high levels of skill achievement. But then some of the other interventions with community health workers, where there wasn't as many resources for training and supervision, you saw modest improvements, but not to the same degree. So this helps with organizations that might have implementation across different regions of a particular country, or maybe across different schools, or even across countries, to be able to have somewhat of a standardized approach. We also did a lot of qualitative evaluation to make sure that people felt this was useful. And as mentioned earlier, a lot of trainers and supervisors felt that it led them to be more objective and confident about the feedback. Many felt that, hey, in the cultural context where I work, often it's hard to give feedback. It's seen as being critical of someone, or it's seen as being subjective. People use the phrase that, when I tell a trainee or a community health worker that they need to improve, the trainee's response might be, well, you just don't like me. But going back to kind of a standardized tool that is adapted for their cultural context, they felt more confident that they could objectively deliver this. And trainees also liked the concrete feedback to then determine what areas to focus on for improvement. So in particular, for you all, wanted to focus on one of the evaluations led by my colleague Mark Jordans and with the War Child Alliance team in Lebanon. And this was to compare two different approaches to training. So this was the same organization, same types of trainees, but in one, the trainer used kind of a standard approach and the EASE implementation guide from WHO and UNICEF. And then in the other, they used the EQUIP approach to competency-based training. Content was exactly the same. But what they found was when they were evaluating the skills over time, using a lot of role plays, giving competency-based feedback, that there was almost a 20% greater increase in competency with the same duration. It was the same exact length. So the same duration of training compared to the training as usual. And we've replicated this in settings in Nepal and Peru with adult trainings, comparing training as usual versus an EQUIP competency-based training to show that the harmful behaviors are reduced and helpful behaviors are increased when you use a competency-based approach with the EQUIP resources. Since the initial piloting phase, which wrapped up around 2022, EQUIP was publicly launched, and it's now been used in many countries around the world, especially in a range of humanitarian and emergency-based settings. The resources are available in many languages. We've worked with colleagues in Ukraine, so there's the tools available in Ukrainian, in Arabic for a number of conflict-affected populations in the Middle East, also other languages such as Chinese, Spanish, Vietnamese, If you don't see a translation on the platform and you need one, feel free to reach out to us. We're always looking for people to help translate additional tools. And it's also been really nice because we now have data to get a better sense of what's going on in the field and to have better understanding of how trainings are working in different settings. So since the public launch in March, between March of 2022 and this past July, over 50,000 people have registered on the platform, and we have about 5,000 active users, those that are using it on a monthly basis. It's been used in almost 1,500 trainings for more than 7,000 trainees. And it's great that we have data now on over 17,000 competency assessments. And this has been really helpful to get a sense that, in many of the trainings, certain types of competencies do tend to improve quite well, such as things like focusing on verbal and nonverbal communication, or maybe describing confidentiality. But we do see consistently gaps in our field. So in many of the trainings, the competencies related to talking about self-harm and suicide don't see a lot of improvement in many of our current curricula. And it highlights a gap for us to pay more attention to this in the future and maybe develop additional resources. So by having this kind of combined global data set, we were able to have a better sense of how to improve practices in the field. I wanted to briefly talk about the newest resource that Equip released, and this was just in September. We had a webinar launching this, hosted by the Mental Health Innovation Network. And this resource is called the Equip Foundational Helping Skills Training Manual, again, freely available on WHO website. So many people, as they were piloting using the Equip different hosts of competency assessment tools, came back to us and said, our trainings are really focused on CBT skills or problem management skills or behavioral activation skills. And we do see improvement in that. But now that we're evaluating things like common factors, we're seeing that those aren't improving as much as we thought they would. We assumed they would just get better with our trainings. We've worked with a number of universities. A colleague at the American University in Cairo talked about teaching master's students CBT. And when he began using the Equip resources to evaluate their common factors or their foundational helping skills, he saw that actually those were getting worse as they were focusing on the CBT skills. So it revealed a gap in the field for resources to better train on these foundational helping skills. So over the past couple of years, led by colleague Gloria Pedersen, previously at George Washington University, as well as colleagues James Underhill at WHO, Fiamma Rupp at UNICEF, have developed this foundational helping skills training manual and piloted this in a couple of different countries as a way to do competency-based training in these areas. And it's a modular approach. So maybe there's just a few competencies that an individual are struggling with, so you can just focus on those, or decide to focus on all 15 competencies, which can be done through 8 separate modules. And I thought this was just, one of the most powerful forms of feedback we got from some of the pilot trainings. So this was from a community health worker in a village health team in Uganda. And she said that after going through the foundational helping skills training and evaluating her skills using the Equip and ACT resources, she said that, also, I'm going to be fulfilled because I know I did the right thing, not just because of the profession, but as a human being. And it was just really nice about this resource is it helps ground people in those basic skills of connecting to one another at a human level, which is really the goal and the most important thing we can do for people, especially children and adolescents who've gone through traumatic experiences and different forms of violence and disasters. The foundational helping skills resources, since the launch, have been used in a range of different settings. So a large insurance provider, Blue Cross Blue Shield, sought us out in the United States because of a program they were doing called Healthy Blue in North Carolina. And they wanted to use this for case managers who often deal with families that are struggling with chronic health needs or high levels of negative social determinants of mental health, and they wanted to improve their communication skills. Partners in Health has been integrating this into a host of their programs, but they got feedback, especially from psychiatry residents, that even in medical school, they weren't trained sufficiently on these communication skills, empathy, promoting hope, and really appreciated this integrated into their specialty residency training courses. Another example is employee assistance programs, where there may be something available to staff at different organizations. In China, we've been partnering with Tianjin Mental Health Hospital to train over 300 nurses and counselors in employee assistance programs in that part of China. So there's definitely a need for future directions. The field of mental health is always evolving, and we've seen a massive shift, both kind of generationally, and also with things, say, related to COVID and doing more remote-based care, to things like chat-based services. And this is really kind of an unknown territory because we have extensive, literature going back 70 years now on common factors in mental health and psychological interventions, but those are built upon the expectation that these are in-person services. Although those can be, pretty well adapted if you're thinking about a video call, it's much different when you have a chat-based intervention. So there's long durations between chats, the amount of text that is shared, the lack of things like body language. So we've been really excited to partner with UNICEF colleagues and other different, and the University of the West Indies and other partners in the Caribbean who have been rolling out more chat-based interventions to do suicide prevention amongst adolescents. And this started in Jamaica and recently, last year, was scaled up to Trinidad and Tobago. And so we've been looking at the people that they're training to do the chat-based therapy. So this is human chat delivered. This isn't an AI chatbot, but to look at their skills and their interactions with adolescents and look at some of those chat transcripts and then score them against the ENACT. And we're in the process of developing ENACT Chat as an approach to look at competencies for chat-based services. But I think there's a tremendous gap in the research in terms of identifying what are the most active ingredients of successful chat-based care to improve child and adolescent mental health outcomes, especially for things like suicide prevention. As I mentioned at the beginning, the inspiration for this work was really targeted towards these rapidly delivered short duration trainings in humanitarian emergencies, training someone on 10 days for a PM plus or 10 days for an ease. But we've seen a lot of interest in actually more specialist training programs. So Makerere University, American University in Cairo, some partners in Bhutan, in other regions of the world have also now incorporated EQUIP into their master's or PhD clinical psychology programs. And with that, they've been able to, over the course of, say, a 2-year program, look at skill development. And this has been really useful in terms of improving quality of practicums and internships, because they'll do a standardized role play before the practicum or the internship starts, and then give that feedback to the practicum supervisor so that they know what areas to focus on for that particular trainee, and then evaluating again after the practicum to see if those skills have improved. So it's been a way to enhance even specialist training. Another area that I think is so important and relevant, hopefully also to many of you listening, has been the increased attention to reciprocal innovation, and that a lot of the work that has been done in low and middle income countries, in disaster settings, is actually desperately needed in high income countries. We continue to have huge gaps in terms of access to care, especially for psychological interventions in places like the US, UK, other high income countries. And I think many of the researchers who have developed these programs in low and middle income countries can teach us a lot about how to do this successfully. And so we've been really guided by them and started to apply some interventions. For example, we're using PM Plus in New York City with community-based organizations. and then using equip to do that competency-based training approach. And we found that having equip as part of that, reciprocal learning approaches to adapting interventions from low-middle income countries into high-income countries is important because of concerns often raised by specialists. So we have had a lot of pushback in the US from psychiatrists, psychologists saying, hey, how can you train somebody for 10 days or on an 80-hour course who they just have a high school or maybe 2 years of college to deliver psychotherapy? And by having equip, we're able to evaluate these skills and say, hey, we're looking at this. We're in a structured way tracking to see if there is potential harm, to track and evaluate, if a person might not have the skills needed to do that, and to also have much more competency-based supervision to monitor their growth and skills over time. So it's been a great advocacy tool to get more of the specialists in high-income countries to buy into this. And it's been really helpful also now as I train the psychiatric residents in my university, because they're interested in doing this, but they often don't get training on how to train non-specialists and what tools they should use. So we now have courses for our psychiatry residents on doing trainings for non-specialists, for community health workers, and other forms of lay providers, and using something like equip as a resource to make sure that they're training effectively. And just wanted to mention also that this has opened up additional avenues for different types of research studies. So the very first version of ENACT was developed through research funded by the National Institute of Mental Health in the US, which has been very interested in mechanisms of action and better understanding how psychological interventions and all interventions work, why they work in certain contexts and not in others. So having a structured way to evaluate competency allows us to do more sophisticated types of moderation analyses or mediation analyses or mediated mediation analyses. And this is better giving us a sense of, does competency improve whether or not somebody attends to an intervention, whether they pick up the skills, whether that ultimately leads to improved client outcomes. But it will guide us in the future in terms of determining how we best train people to produce kind of the shortest, most effective trainings for the most optimal client outcomes. So I hope this has been useful for you all in terms of kind of any background that you're coming from, and that if you are someone working in a humanitarian setting, that you might be interested in adopting equip to improve the quality of your training and supervision. If you're someone involved in research in any part of the world related to psychological interventions, that you might consider using equip, not only to study how the intervention is working, but also to guide scale up and think about setting benchmarks for minimum competencies in real world settings. And then also, if you are directing a training program, to better prepare the next generation of mental health specialists to be more effective at training, supervising, and supporting non-specialists so that we can really get the most amount of psychological interventions available to the greatest number of people around the world. Thank you all very much. And this is my email address and our center, gwglobalmentalhealth.com. Feel free to reach out with questions or interest in collaboration in the future. Back to you, Julia.
Thank you so much, Brandon, for this fascinating talk and summarizing such an enormous amount of work so succinctly. And I see we have some supportive emoticons popping up as well. Yeah, just I think incredibly helpful, especially as we think about practitioners and settings delivering multiple programs at the same time, and how we can better assess this, and incorporating potential harm as well, I think is something so important and so rarely done in this assessment. So really incredibly interesting and useful to see this. We have a couple of questions, so if you're happy to answer them through this connection. Yeah, we have a question about whether, since this looks like a useful training approach for therapists in higher income countries and non-emergency settings, as you started talking about as well with the New York example, we have a question about whether there is already some evidence of this approach for these types of higher income settings.
Yeah. So I would say we have a trial. We're in the final year of it right now. It's a 5-year trial with PM Plus. And I think we've trained almost 100 different community-based organization staff to be able to do these interventions. And so we'll be able to look at, what degree the different competency levels predict the outcomes of those clients. But I think just from an implementation perspective, it's been super helpful so that we can give feedback to the different community organizations and to the mayor's office in New York City about monitoring the safety. So from a kind of feasibility and acceptability of this approach, we've had a lot of positive feedback.
Thank you, Brendan. I think we have 2 more questions so far. One is about whether this approach has been implemented in the Gaza Strip.
Yes. So War Child, as I mentioned, Mark Jordan's has partnered on pretty much all of these. So War Child now uses this approach, and they look at things like how competency is also associated with attendance at sessions, also associated with the kind of scores that children have going through some of their different interventions. So they've been kind of from an implementer perspective, rolling this out in many of their different programs in different parts of the world. The We Act has also been translated, as I mentioned, to different languages and been evaluated for its use in a number of Arabic-speaking settings.
Thank you so much, Brendan. And you've mentioned a few trials in Jordan and other countries in the region as well. The final question that we have so far is how quickly can this mental health task shifting training be set up in acute humanitarian situations?
Yeah, so it really depends on what the content of your training is. So if you're doing like the foundational helping skills training, that's can be done in 3 days. If you're just focusing on like these communication skills, if you're doing like an ease training or a PM plus training, most of those are designed for about 2 weeks, but then a period of rather intense supervision. We've found that if you already have someone in your setting who is a trainer, an existing trainer on any of these interventions, getting them to use Equip and getting oriented to Equip, we can often do that through a number of like web meetings like this for a couple of hours to kind of orient them, get them comfortable, and then there's some practical practice time. WHO has done a number of training of trainers. Those are typically 2 to 3 days to really kind of develop skills. But if you are an experienced trainer or supervisor, integrating Equip does not take a lot of extra work, and we're happy at GW for people to reach out if they want more support getting started on that.
Thank you so much, Brendan. I don't see any questions posted yet, so this is one final call for any questions our audience would like to ask. Please post them in the Q&A or the chat. And since we have a couple more minutes, maybe I'll sneak a question till we wait for any final ones. Since you were talking about training, I mean, I think we know that, as you mentioned, assessing fidelity and competency in interventions, in evidence-informed interventions, can often be complicated and costly. And one of the challenges is often getting reliable measurements through inter-rater reliability and the ways you've talked about in terms of having certain specific examples and anchoring can be really helpful for that. I wondered if you have found it also necessary to do some kind of calibration or training in terms of reliability across different supervisors, or have you found that with these anchoring examples it's quite straightforward in terms of getting similar assessments across multiple supervisors?
Yeah, so the platform actually includes visualizations on that. So I didn't show it in this presentation, but happy if anybody's interested in exploring that more. So essentially what it is you, Yuli and I, we watch the same, video of someone or watch the same role play. You rate it and I rate it, and then it'll eventually, the platform pulls up then a comparison of our ratings. So it's a way without having to do like a formal inter-rater reliability, like statistical calculation, just to see how many of the competencies, which competencies you and I agree on, which competencies we're rating differently. And that is kind of a quick and dirty approach to be able to get some of that agreement. And so we find that that really helps to spend some time watching some of the videos or doing other things jointly to get comfortable and calibrated. But the addition of those specific behaviors really helps to get those levels to match up more. When we've just in the past used earlier versions of the tool that just was like level 1, 2, 3, or 4, quite inconsistent, because what's a 2, what's a 3? But with the behavioral anchors, it does lead to a lot more agreement.
Oh, thank you. That sounds extremely useful and much more user-friendly than trying to explain what intercluster correlation is to anyone.
Yes, exactly. Right.
So that's really useful. So I think we have one more question from a master student of clinical psychology in Nigeria who would like to get trained and find out more about EQUIP, and is asking whether you know of any trainers or specific projects implementing this approach in Nigeria.
We did try a little bit with Oyegareje with a project that was more MH gap focused. So we did some initial exploration, but I would say there's definitely room to go into more detail. So I would suggest, I shared my email earlier. Feel free to reach out to me and we can talk more about use. In terms of West Africa, we've also done some programs in Liberia with this, recently trainings in Sierra Leone of primary care workers with this. So we have a couple of kind of adapted West African vignettes and would be happy to explore more use in Nigeria specifically.
Thank you so much, Brendan. So Kehinde, I hope that's helpful, and we look forward to your future work applying this in Nigeria. Yeah, so you have thanks for answering that question as well. So I think we are at the end of our time, and we have answered all the questions. And thanks so much, Brendan, for your generosity in sharing your contact details. Finally, I'll mention that in the chat, our colleague Gide has posted a link to the mailing list and social media for the Wolfson Center for Young People's Mental Health. And that's where you will also be able to find, by following these links or going directly on the YouTube channel for the center, the recording of today's lecture and past and future lectures as well. Thank you very much, Brendan, for your time and your generosity. And thank you to our audience for participation and for all your questions.
Thanks, everyone. Great to see you.
Thank you.